Hi, I'm going to be continuing on with my video series of phantom pain development and treatment with my next video here called Treatments of Phantom Pain. And first off, I'm going to be looking at pharmacological treatments. So the focus of most current treatments is managing the symptoms of pain, not treating the underlying central nervous system changes. Consequently, phantom pain therapies are largely ineffective and treatments don't usually provide a cure. Management of phantom pain often begins with analgesic pharmaceuticals. Non-narcotic analgesics such as acetaminophen and non-steroidal anti-inflammatory drugs, so your aspirins and ibuprofens, are the most commonly prescribed treatments. NSAIDs, or non-steroidal anti-inflammatory drugs, reduce prostaglandin synthesis, thereby reducing neuron sensitivity to painful stimuli. Although acetaminophen can reduce phantom pain, the mechanism of its effect remains unknown. Opiates are another class of analgesic drugs used for the treatment of phantom pain. Unlike the NSAIDs and acetaminophen, opiates are associated with a large number of side effects, so they are not as commonly used. These pharmaceutical treatments have little to do with the neuroplasticity that I've just discussed in my previous video, and therefore their effectiveness is not as powerful as a mechanism-based treatment. When analgesics are not successful in controlling phantom pain, patients may be prescribed tricyclic antidepressants and/or anticonvulsant medication. The effectiveness of antidepressant medication for the treatment of phantom pain has not yet been subject of a randomized controlled trial. Therefore, the true efficacy of antidepressants really remains uncertain. The efficacy of anticonvulsants is also uncertain. A typical anticonvulsant medication prescribed for phantom pain is gabapentin. Unlike antidepressants, gabapentin has been evaluated in randomized control studies. However, it has produced mixed results. Therefore, the use of tricyclic antidepressants and anticonvulsants in a clinical setting relies really on limited supporting evidence. Next, I'm going to be talking about minimally invasive and non-invasive treatments. So, pharmaceutical treatment is often combined with other therapies to achieve the best patient outcome. One non-pharmacological treatment that can be used is mirror therapy. This therapy is designed to reduce the visual, motor, and sensory incongruence that a patient missing a limb experiences. Mirror therapy uses the reflection of the remaining limb to trick the patient's brain into believing that they still have both limbs. It's a really interesting treatment plan. One randomized control study reports that mirror therapy is capable of reducing phantom pain for the lower limbs, and that was done by Chan et al. In 2007, so it's a fairly recent study. However, another study also reports that it does not reduce pain more than a placebo, and that was done by Brody et al. In 2007. These conclusions emphasize the need for further research into the effectiveness of mirror therapy as a treatment option. Another non-invasive or minimally invasive treatment that's used commonly is transcutaneous electrical nerve stimulation, or TENS, and it's another proposed treatment for phantom pain. This treatment involves the delivery of electrical stimulation to the body using electrodes. TENS has really only been shown to have a small effect in controlling phantom pain. Other minimally invasive and non-invasive treatments used for phantom pain include behavioral therapy, hypnosis, massage, and even acupuncture. The success of these therapies and the amount of research performed regarding them has been very minimal. Moving on to surgical treatments, once all other methods have failed to provide relief, patients may turn to surgical treatment, but it really is a last resort because it does have the possibility of very adverse outcomes. Case studies have demonstrated that spinal stimulation and stimulation of the motor cortex has effectively reduced phantom pain. However, case studies really do not provide concrete information that's needed by clinicians to make educated decisions regarding surgical treatments. The paucity of large-scale studies regarding surgical treatments emphasizes the need for more research in this area. These surgical procedures are not well understood and pose many risks. Therefore, surgery should only be considered for patients that do not gain relief from other therapies. An understanding of phantom pain has really just begun. Consequently, treatments remain largely in a state of infancy. So just to conclude my video series, the idea that the brain can generate both the experience of pain without injury and the sense of body without flesh is simply astounding. Although the understanding of phantom pain has come a very long way, specific knowledge regarding the mechanisms of phantom pain development continues to evade researchers. An investigation into the architectural changes of the central nervous system has revealed that central nervous system plasticity could be a primary factor in the development of phantom pain. However, the regulatory effects of psychological and peripheral factors must not be overlooked. Armed with this new information, the horizon really can only hold more effective treatment and prevention options for phantom pain. Thank you.